Very good. Well, welcome. My name is Dave Beccattini with LifeAire, and we just want to thank you all for coming today to participate in I think a very important topic and something that is well deserved for our long-term care and senior care individuals to get some of the proper praise they deserve for the great work they do. So, without further ado, I'd like to introduce Dr. Catherine Morlow, founder and CEO of LifeAire.
Thank you, Dave. Can everyone hear me? Yes. Good morning, and welcome to our roundtable of esteemed panelists. It's been a historic 2.5-year period of extreme and very frightening challenges, especially to those caring for others in senior living, as many of you are here with us today have done so, as well as in the acute care setting. It's also been a time of exceptional collaboration and teamwork between providers, scientists, and epidemiologists. This morning we're here not only to recognize the heroic efforts of those providers in senior living, to protect the efforts made to protect their staff, residents, and families during and beyond the pandemic, but also to discuss the most current information on the management of airborne pathogens, their roles in wellness and infection, as led by Erica Kimmerling, Senior Policy Advisor for Public Engagement and Science of the White House Office of Science and Technology Policy Committee. We'll also be discussing the resources and financial support available to best support all providers of senior living, as well as the ongoing efforts towards such support, as led by Congresswoman Susan Wild, her staff, Austin Cawley, Director of Legislative Affairs, and Natalie McDonald, Vice President, Member Excellence, each of whom we welcome from leading HPA. Finally, we welcome and introduce our esteemed providers of senior care in our great state of Pennsylvania. We welcome Bill D'Andrea, Vice President of Operations of Country Meadows, Michelle Wharton, Executive Director of Feeding Ministries Allentown, and Kelly Bach, Director of Facilities, Feeding Ministries Allentown. We look forward to a robust, lively, and highly informative discussion. And we thank each of you, both those of you here in person, as well as those joining us virtually, for your participation. We look forward to your thoughts and questions throughout the event. Our singular goal is to have an open dialogue and subsequent course of action between our providers and those who can support and drive the policies necessary to provide the resources as identified and needed. Finally, we invite everyone to join us for lunch after the roundtable. We're grateful to Angelo Valletta, President and CEO of Ben Franklin Technology Partners, and his great staff for their kind invitation to host our event today. We're most fortunate to have Angelo as leading the critical and vision-driven Ben Franklin Technology Partners organization, as well as being such a significant member of our community. Angelo, we thank you and your team for hosting our great event.
Thank you, and I appreciate allowing me to say a couple words. Thank you for joining us, the folks here at the roundtable and the folks that are on the video conference. But thank you for allowing us to host this incredible event. I'd like to welcome, of course, Congresswoman Wild and for her efforts as it relates to collaboration. And that's one of the things that Katie mentioned, collaboration. This incredible facility and ecosystem would not be here if it wasn't for the public-private and the stewardship of that collaboration. So this facility that is gathering here with Congresswoman Wild, strategic leaders from prominent organizations like Phoebe, like Country Meadows, like OSTP, and of course all of our distinguished guests here. We here, Ben Franklin Northeast PA, we own and operate not only this facility here at Tech Ventures, but also the Bloomsburg Regional Tech Center. Combined, it's 150,000 square feet that has graduated over 70 firms and has produced over 7,900 jobs in the great state of Pennsylvania. The collaboration of that public and private and creating that ecosystem is the perspective on how we drive and promote and sustain economic development here in Northeast PA. And we do that by 3 ways. We do that by supporting our early stage organizations. LifeAire fell into that category several years ago with an investment. Our established manufacturers, now Katie and LifeAire falls into that category of established manufacturers, where an organization morphs from an early stage to established manufacturing, and that third level of that community involvement, that public-private, that support the ecosystem that drives organizations like LifeAire to prominence. And we just seen in the news and seen it on video, a size of the shipping container being delivered to the Lehigh Valley Airport. It was amazing to see on video. I just wish I could have been there live, quite honestly. But good stuff, all supporting our organizations as it relates to early stage and established manufacturers. And it's key that we don't forget our established manufacturers. As early stage morphs into established manufacturers, those established manufacturers that we support on a consistent basis, that's where combined we're able to refresh, retain, and reimagine jobs here in Northeast PA for the great state of Pennsylvania. So without any further ado, I'd like to basically hand it back over to Dave. But as I mentioned a few times, Katie and LifeAire is a shining example of that collaboration efforts to where we're able to support our Northeast PA, where we are a top 5% investor in the United States for organizations like LifeAire. And this Tech Ventures, we welcome you again. And at this two-time Incubator Award winner over the last 10 years. So thank you very much. Dave, back to you.
Thank you, Angelo. Again, at this point, we want to take some time to recognize some of the great work done by, first of all of the long-term care communities out there, but we do have a couple that are local here in the Lehigh Valley and in Northeast PA. They're going to share some of the stories and some of the heroic efforts that their folks did during the pandemic. And so I'd like to introduce Congresswoman Susan Wild, who is going to lead that discussion.
Thank you so much, Dave. And I'm really happy to be here with all of you today. Angelo, this is, I don't know, I think I've been here a number of times now for different events. It's such a great facility. It's a great place to do a conference like this, or an event. I've been in the room next door, and of course I've met with a lot of the startups and entrepreneurs downstairs. So it's really a wonderful a jewel of the Lehigh Valley. And of course, I'm thrilled to be here with LifeAire. When we first met, I was very impressed by the work that you had the foresight to do. And since that time, and I don't know when it was because with COVID, time is just a big blur, right? I don't know when it was we met, but I will say that we've also enjoyed working with you from our Washington office and advancing your mission as well. So I just want to say a few words before we get into the stories. You know, the people who are in this room, and of course everybody that you work with, are truly healthcare heroes. And I know we've used that term an awful lot over the last few years. And I think it really is very, very important that we continue to hear the stories of what happened in all kinds of healthcare facilities during the pandemic, because as most of us were retreating to the safety of our own homes and gazing out from behind a laptop screen, healthcare workers were the ones that were going into facilities, making sure that they were providing wonderful care, but also putting themselves at great personal risk and having to deal with a lot of uncertainty that residents and family members and patients all had. I know it was a really, really stressful time. I was honored to introduce and shepherd through a bill that was a direct result of the loss of life of an emergency room physician in New York City, Dr. Lorna Breen, who died by suicide at the peak of when the pandemic was really hitting Manhattan. And sadly, as her parents say, they consider her to be a victim of COVID, even though she took her own life. But she was the front line. And so we introduced a bill called the Dr. Lorna Breen Act, which actually creates programs that are aimed at connecting healthcare providers with mental health resources, but also designed to eliminate the stigma of all providers who receive mental health care themselves. And that is everybody within a healthcare system, not just the physicians or the nurses. And I think it's really important that we recognize the stresses of those jobs and that so much of it is taken home. And so I'm really proud to say that the Dr. Lorna Breen Act actually passed the House, it passed the Senate, and it's been signed into law by President Biden. So I was thrilled about that. But it's just an example of one way that I think that we really need to recognize the challenges that face all healthcare providers, but today, of course, we're here to talk specifically about your industry. And I want to learn more. I feel as though I still have a lot to learn about what transpired over the last few years, and how we can make healthcare better, particularly for our senior citizens. I'm just really, honored to be here and share this experience with all of you and see what we can do to all work together to continue to make advances in this field. So with that, I'm going to pass the mic, so to speak, even though I don't have a mic, to Michelle, whose last name I don't think I have right.
Morton.
Yeah, okay, Michelle Morton from Phoebe Ministries, and Bill DeAndrea, Vice President of Operations at Country Meadows, so that they can bring to light some of the experiences they've seen. And with that, take it away, either one of you.
Okay, sure. Well, for us, I think so often we focus on the institution and not the people. And without the people, Country Meadows wouldn't be what it is. And our coworkers rose to the challenge during COVID, from our managers, our nurses, our direct care coworkers, and our dining team. From connecting residents with their families in different ways, with window visits, and setting up unique ways to support them via FaceTime or Zoom or anything like that to keep that connection. Parades for anniversaries and birthdays when we couldn't have people come in, but it was just so amazing. And I was overseeing a facility during COVID and during the beginning of it, and I can personally tell you it was scary at that time. I recall when we had our first outbreak, and it was in our secure dementia neighborhood. And going down there, the things going through your mind was, you didn't know what to expect. Everything was new, everything was scary. It was like, are we going to be all right? Am I going to be all right? Going down there, how am I going to present a strong front for my coworkers and my team during this time when I don't know what to expect? And having a conversation with Katie last week, just talking about the very beginning when we had no guidance and really were flying blind. Some people passed away rather quickly. I always recall we were working with hospice, and one morning we were having a conversation, and 3 residents get wheeled out by the corner at that time, and you're just thinking to yourself, is everyone going to die? But I have to say how everyone rallied and supported one another, and the residents and the families was just truly amazing. And we literally had no real guidance of what to do. It was, you got COVID, you go on hospice, you get comfort support. But we learned a lot. We had a lot of initiatives through those few years, and really came out ahead and better for it. We'll talk more about that, but the stories are going to probably go on all day if you'd let me. But it was truly amazing to see how the coworkers banded together. I had people go to other campuses to support with staffing when other teams were out with COVID, taking time away from their families, and again, getting COVID themselves and not knowing what to do. But, we really were very proud of Country Meadows with how we reacted to trying to get PPE, getting PPE for our coworkers, supplying them with paper products and food pantry at the time, because we know things were very tight to come by at that time. So, it was just truly amazing to be part of that. It was scary at the same time. Going home, personally myself in the beginning, taking off your clothes in the garage and putting on a different set when you walk in the house, because my 6-year-old and 10-year-old were there, and they were just worried about what's going to happen. So it was quite an experience, and I hope we don't have to do it again. But I think we learned a lot from it, and if we did have to confront that, we'd be better prepared.
So I've only been at Phoebe a month, so I think Kelly can talk in more detail about some of the things that Phoebe did. But I think in general, I just agree with everything that Bill said. Like, I think our organizations really did rise to the challenge. And, I think it was something, a worldwide pandemic of this scale, no one was really prepared for. So trying to work with the team, and when you talked about the fear and the uncertainty, one of my first memories was having a nurse's aide crying in the bathroom and having to go in, and we didn't even have any cases yet, just hearing what was happening on the news, going in and talking to her and trying to reassure her that, yeah, we're going to be okay, when I didn't really know that we were, but trying to provide that moral support for our team. And I would say as far as the struggles, I think all healthcare organizations face similar struggles, but I think what was different for the long-term care piece of it was just public perception. The public likes to vilify nursing homes, and I think that was really hard for our team. I think hospital settings received a lot more moral support from general public, and I know of some specific instances where I've heard cases where someone dies in a hospital, and the support for the nurse is, oh, I'm so sorry for you, I know how hard you worked for that person and what it means to you to lose them. But it kind of felt more like on the nursing home side, it was, how could you let them die? And I think that was really tough for our team, because we had the most vulnerable population. So when you're talking about people dying all over the world, and we have the most vulnerable group, that felt so unjustified and so hard for our team. Many nursing homes do an excellent job. So to have everyone lumped together based on a few that might not, and to say that was very hard emotionally for all of our team members.
And I think probably compounding the problem for nursing homes was the restriction on visitors. So you had family members who were worried about their relative who was in the nursing home, but furious that they couldn't come in and see them. So you had that stress on top of it. I mean, I remember it pretty well.
Yeah, just when you needed the family support for your residents too.
Right.
So you're trying to provide that support. I know like window visits, hugging booths, all the things that different communities did. The place I worked at that time, like all the extra work that we did, like you said, we're not sitting at home. We were working harder than ever and more hours than ever. We had routine phone calls to family, giving them updates on their resident situation. Even if it was just reassuring them that they're okay, they don't have any signs and symptoms, or yes, they do, and here's what we're doing. Like that amount of work. And since we have a congressperson here, I think, one of the keys that I think we could definitely do better is just the amount of reporting that we did. So many different reports to different agencies that were all collecting the same information, but in a different format and on a different website. Like just when we needed to be with our residents and our team members more, that was time is up, just the amount of reporting. So, anything we could do for the future, having one consolidated report that all agencies use, I know I would greatly appreciate the hours I spent reporting.
That's a fair comment. And I mean, we've said many times in Congress that if nothing else, we have to learn some lessons from this pandemic so that in the future we don't repeat the same mistakes. So, thanks for that input.
And Kelly can speak more to the Phoebe experience.
Hello. Thank you for entertaining us today. So I was more in the weeds. Being the facilities director at Phoebe, when all the directives come out and excuse me, the mandates and everything. So in March, I remember having a meeting with our executive director and saying, we have to create a COVID unit. We have to keep this separate. We have to keep these people away from the population. So we did have a decommissioned area that was our overflow, and we took a 103-year-old building that hadn't been used for probably 6 years and made this COVID unit out of it that the state came out and inspected, and airflow was right, everything. It was closing dampers. I don't want to get into the weeds on all of that, but it was a monumental undertaking, and I remember stepping back and saying, God, I hope I'm doing this right. And I think that that's the biggest takeaway from me through all of this, was that the weight of every decision that you made could impact somebody's life. And they live there. They're not there for 3 or 4 days. They're there for their life. So lo and behold, in April, we have a 4-campus community, and one of our campuses went down. So not only did the staff of the campus,
April 20th.
April
Yes.
2020, yeah, April 2020. So right after we made this COVID unit that I'm unsure of, we had a sister campus go down, and we decided that we needed to evacuate because the residents were sick and the staff was sick, so there was nobody to take care of the sick residents. So it was a huge undertaking, buses back and forth from Wyncote to Phoebe Allentown. And I remember it was a 6-hour event, and all of a sudden they said, oh, we need 37 beds. Well, I had 19 in this COVID unit. I'm like, what? We're on our way with the first bus. I'm like, okay. So we did it. And we managed to contain COVID in that area. We had no COVID for our residents for almost a whole 6 additional months. So they came, they were taken care of. We lost some. That was a really hard, as Bill said, that was really hard when you lost your first person. Because these people were being cared by people they didn't even know. So they came and died with us. So that was really difficult. Then we got to send them back home. They got to graduate, so we took them all back. We also, when the state said we could visit again, we had to keep them safe, right? How are we going to keep them safe? How are you going to keep them safe? You know, you can graduate from outdoor visitation. So we built visitation stations where plexiglass, wood, and there were 6 of them on the patio, and they were 15-minute visits. We had microphones in there and headphones, and it was really cool. And so I had a brilliant idea, like everybody needs to hug their mom, right? Everybody needs to hug your mom. You need to hug your mom when you haven't seen her for 8 months. So we created a hugging booth that was really successful. And if you were ever having a bad day, you walk out to the hugging booth, because when you saw people getting to hug your mom for the first time in 8 months, it was an amazing place to be. So good stuff. We did all kinds of good stuff. So everybody did all kinds of good stuff. We all came up with whatever worked best. It was definitely a charm. And my husband has lupus, so I would come home and take all my clothes off, and nobody was allowed to go in the
Well,
bathroom.
and that's one of the things we didn't really touch on that much, but the risk that the providers were taking for themselves, for their family members, and that kind of thing, which you can't forget. And as I said, I think we have to keep telling these stories, because the fact of the matter is, even now, a few years later, it's almost hard to remember just how awful that period was. We're not even a few years, a couple of years later. And you can imagine that in 5 years, it will be just a distant memory. People won't even remember what it was like, hopefully. And I mean, I say hopefully because hopefully we won't see something like this again anytime soon. But you know, but I think it's really important that people understand just how challenging it was. It seems like too soft a word. Did anybody else want to add to?
Hi, I'm Melanie Kohler. I'm Chief Technology Officer here at Ben Franklin. And prior to this, I have been in post-acute long-term care for about 17 years. I worked at PB Ministries as the director of IT, and then went on to serve as executive director of a community for a few years. I worked at Meeting HPA for a few years as well. Hello, Austin.
How you doing?
And also then went on to work in another community before coming here to Ben Franklin. And the pandemic, I'll echo what we all know and heard here today. And I would just say that mental health for both residents, caregivers, and family was a top priority for all communities. Technology was huge, and a lot of organizations were able to help fund technology and quickly get that into the hands of staff. So suddenly CNAs became technologists as well and helped set up Zoom calls. And we all learned to Zoom overnight. Imagine an 80-year-old who hadn't been able to spend time with family. And to the point, I don't think we appreciate when we're not in that environment the psychological trauma that this created for residents who weren't allowed to leave a 10 by 10 space. We saw in the press folks in New York City who were stuck in their apartments, and we heard about that. And then we turned to this, and we had these poor residents who, it was kind of diabolically opposed to our model. This was their residence, their home. They could do whatever they want, but they couldn't leave the threshold of their room for many weeks and months. So the community's got incredibly creative, right? I also said there were a lot of funding opportunities, not only for tablets and carts. We also saw a lot of deregulation, which really helped, and I think echoes back to Michelle. We were doing a lot of reporting. Thankfully, some of the security guidelines on how we could do telehealth visits, limiting that made things so much better. It took a little time to get there, but we were able then to provide those services that we probably wouldn't have been able to do in all walks of life, because there are some communities that are well funded and there are some that are surviving on Medicaid alone and just didn't have that reach. So, there was a lot going on, and I think everyone tried to do as much as they could. Maybe we could have done things a little differently. We learned a lot, but there was a lot of positivity, and cutting some of that red tape really made things much more manageable.
And the changes to telehealth are some of the changes that I think we're going to see just that will last. We did them because of the exigency of the situation, and everybody suddenly realized, this works.
Yes.
We need to do more of that. So.
It worked, and people were happy with it.
Yeah.
I think we assumed that people might not like it or it might not work, and I
Now it's
remember setting
mainstream.
them up. Yes, exactly. So, several things came out that I think are positive, and we need to your point, keep it as hopefully it's a distant memory, but take the good and the lessons learned and really execute them to further the mission.
Well, thank you. For anybody else that wanted to?
Yeah, I'll go. I'm Andrea Tessier. I'm with Penn State University, and we have a nursing program. And during that time, so it's crucial that students go in and they have lab experience and clinical experience, and we have great partners with our clinical sites. Of course, we suddenly could no longer go to these sites. A lot of them are nursing homes, and so we had to get very creative. But at that time, the university shut down, like so many other places, but our nurses and our faculty particularly would be working in nursing homes, and they never stopped, right? They would leave their jobs with what they were facing and still push forward, and they would show up. We would be the only people on the campus. It was a ghost town, except for our students, where they just kept plowing through to try to get that training and that hands-on. We did get creative. We tried some virtual lab software, and that worked in some areas, but it was extremely important that they get that hands-on practice, and it's so impressive that they just kept going, and the faculty kept going. I also noticed that we had a spike in interest for people wanting to get into the field. They were heroes, and then suddenly they were villains, and they didn't want to get into the industry. It was such a switch for us to try to keep the interest going because our healthcare providers were so desperate for staffing.
Mm-hmm. And I think that problem has continued.
Mm-hmm. Mm-hmm.
If I can make one quick, I'm sorry.
I'm going to make a quick comment because I'm from LifeAife, and we provide services to individuals with developmental disabilities and autism with ADHD homes and day programs and I was on the board of directors at the time. I've been the CEO for a year, but I was the program officer at Kids Peace when this occurred. And Kids Peace was very focused on what we could do to set up a unit, like you said, in our hospital. And we were very thankful for our regulatory bodies who said, do what you need to do, because we weren't licensed for that, but they were allowing us to move forward and try to set up a place where people, especially our kids who are COVID positive, could be cared for. And we went through some of the things that you all went through, but I remember us sitting around talking in a leadership meeting, and we thought, we're challenged, but at the time, if you remember, kids weren't really affected by it, and they would bounce back. They'd get a cough, a temperature, and they would bounce back. And our hearts really went out to all of you who were running the long-term care facilities, because we just thought, if we're blessed in any way, we're in the kid business, and typically it's very unforgiving. But we thought at that point, maybe we were going to get it passed. Of course, it ended up hitting everywhere, and being on the board at LifePath, then we were experiencing the other side of things where we have, relying on technology and teaching parents of the individuals in our group homes who themselves are 50, 60 years old. Their parents are elderly, but we're coming to visit and now having to use technology, and we still utilize all of that today because we still have outbreaks in some of our group homes. We're still shutting down a group home for a week because staff or individuals are testing positive. Luckily, we know exactly what to do now, but that technology really helps us during that period of time because dealing with the families not able to see their children certainly was really heartbreaking. So I was very thankful for many of the things that allowed us to move forward at Kids Peace and like that. But we're still learning. We're still learning more about this. And I think it was just a very, in the beginning, chaotic time where so much information was coming at you. And like you're saying, you're trying to make a decision that you think is best, but you're just not sure. So I'm thankful for where we are today and hope that we don't have to go through that again.
I think with all the information, because it was information overload at the beginning, you're trying to keep up with what's happening and things were changing so quickly. Just when you get the staff on board, this is what we're doing now, and you're going back to town, well, now we're doing this.
The inconsistencies, I know, were really very challenging.
Yeah.
Every Friday about 4:30.
Yeah.
But
Get a new Han.
But I think the value of our professional organizations with helping us digest that information and having group calls like Leading Age was one. The regional healthcare coalitions, those I found really helpful because it wasn't just like our sector them that would be on those calls. That was all the healthcare providers and the emergency planners, and so all those routine calls. That was very helpful to have those resources because you're trying to read and digest it yourself, but having groups that were helping, read and interpret it, and how do you then implement this next change?
The conversation around the healthcare side of it, the support side of it, it's amazing. One word comes to mind, it's resiliency. The resiliency of the heroes that are speaking today, millions of others, right? So, but as a business leader and an individual that lost his father in November of 2020, so I was one of those that did not see their parent from February, right? The last time I saw my father was February. But the facility he was in, clockwork, would call me and say, "Dad's okay." Now, he had dementia, so he hardly recognized who I was, right? And but it was more about, is Pop okay? The facility opened those lines of communication. We shouldn't forget about all those other heroes, those construction workers and electricians that created those hugging stations for us, right? Our wonderful government being able to set the path to create a vaccine in record time. Our government to distribute a very complex vaccine at a time that there was still a lot of uncertainty, just amazing things. So we should be very proud of ourselves in regards to that resiliency. Proud of the way we have companies like LifeAire that pivoted with COVID-19 and can eradicate airborne pathogens down to anthrax. Of course it can eradicate COVID-19. And organizations like the Lehigh Valley Airport putting that product in. Our Ben Franklin Tech Ventures has LifeAire product. So the air we're breathing, the air is being eradicated with those airborne pathogens by LifeAire. So just wanted a couple comments in regards to that resiliency. Thank you, every single one of you that had to deal with that uncertainty. And it gives me faith that if and when something else happens in the future, you know what, we've learned some lessons and we're going to be able to manage it going forward. That's a beautiful place to be.
It is. Well, that seems like a good place to segue into the discussion by Dr. Warlow, the founder and CEO of LifeAife Systems. And I have to tell you, I've thought of you so many times since we first met. She's truly an amazing figure for anybody who doesn't know, not only here in our local community, but in the medical community nationally. You know, long before any of us were thinking about airborne viruses, Dr. Warlow had already founded LifeAife Systems and overseen devices installed in, this is the part that really resonated with me. I remembered it from our first meeting. They were installed in more than 50 IVF labs. That was like the starting point, right? And maybe you'll explain why that was the starting point, but I thought that was really interesting. And then operating rooms, intensive care units, neonatal facilities, and critical care areas within hospitals. And you understood that this invisible thing that surrounds us all, the air that we breathe, is a critical but often overlooked factor in positive health outcomes. And in 2016, Dr. Warlow approached Phoebe in Allentown to begin a dialogue to install LifeAire's air purification system into one of Phoebe's long-term care neighborhoods. And that began the joint partnership between Phoebe and LifeAire to develop and install and study the potential positive effects of LifeAire's advanced air purification technology. And as I said, that was in 2016, so we weren't even thinking about the pandemic at that point. So the foresight is quite amazing. I'm going to let you explain the findings in the 15-month-long study, but I can tell you from what I've read, and there is a lot that's publicly available. The results are overwhelmingly positive, and I'm really looking forward to hearing more. I also, I just learned from Kate this morning that LifeAire just installed a purification system at our local airport this week, right? Which is also very exciting. I was out at the airport a couple weeks ago with the Secretary of Transportation overseeing some of the infrastructure projects that are there. And of course, we're all really excited about that infrastructure package that we were able to pass. But things like the quality of the air are things that most people don't ever think about. And we don't necessarily want them to have to. We kind of want them to be able to take for granted that they will be breathing clean air when they're in crowded places, in airports, going through TSA areas and that kind of thing. But of course, if they're not, that's really detrimental. So I'm just fascinated by your foresight. So I just wanted to turn it over to you, Dr. Warlow, to talk a little bit about what you learned, what motivated you, and how this all came about, and where we are now with it.
Thank you.
Thank you.
Thank you very much. I just moved to Expo. So thank you very much. Given this critical topic of discussion, I was asked to provide just a brief presentation specific to our current knowledge of airborne transmission of viral and bacterial pathogens and their role in senior resident and staff wellness. In doing so, I'd like to focus on really defining the clinical significance of air quality to staff and senior living residents, briefly review some of the air filtration technologies currently available, and primarily empower your decision with operational data would be a huge take-home message. And finally, discuss the environmental, clinical, and economical results associated with the study that the Congresswoman was referring to with feeding. Just setting the foundation for our discussion, some key points of the pathogens that cause illness and infection. 69 to 80% are airborne. 69 to 80%. Fact number 2, greater than 90% of the infectious surface fomites, anything on your bed tables, your railings, your OR sterile tables, 90% originate from the air. Your conventional MERV or HEPA filtration is not providing adequate remediation, and this is why. So your typical filtration system is a capture system. So it's going to capture the pathogens of a certain size. And then they're going to continue to grow right above the space you're trying to protect. They need 2 things, food and water. Food are the other organics that are captured. Water is the humidity, it's just the humidity in the air. And a lot of your chemical pathogens, your volatile organic compounds, are going to go right through, as well as some of your smaller viruses. This is an image that my colleague Eric Marsh took. This is downstream of a HEPA filter protecting a highly sensitive clinical space. And you can see the effervescent green coating the ductwork. Unfortunately, this is seen far too long. That's aspergillus. So those are fungal spores that bypass the HEPA system. The initial aspergillus was captured, but then the spores can splinter off and actually pass through the HEPA filter and line the ductwork immediately in front of the space it's trying to protect. Now, aspergillus can be highly a common source of infection and illness among patients and residents. So we've received a number of inbound calls just asking questions because the air filtration, there are a lot of technologies out there. It's become somewhat of the wild, wild west. And we've had a number of calls just saying, help us understand which is effective, which aren't, what should we invest in. And to simplify, there are really 2 types of filtration. There's additive and there's subtractive. Most are additive, like your bipolar ionization, BPI, needlepoint ionization, plasma, hydrogen peroxide, PCL, a large list. And they function, they'll remove some of the infectious pathogens, but they do so by adding constituents to the air, typically producing byproducts, which can be as harmful as what you're trying to remove. The point that is of greatest concern to us is the lack of operational data showing efficacy of the different technologies. It's important to us, it's one of our core, we lead with data. And we lead with operational data. So if someone approaches us and says we want to protect X size area, this is what we do in that space, then we want to know that we are delivering the metrics that we guarantee specific to their space and with what they're doing. Everyone's doing a remarkable job on infection control and cleaning protocols, but that's not completely eliminating the problem. And finally, air quality is extremely dynamic. It depends on who's in the room. How ill are they? Perhaps they're asymptomatic, but they're shedding. What SOPs are in that space? It's a constantly moving metric as far as the indoor air quality. If you think about some of our most common activities, I listed these in order of shedding the fewest viral particles, and it only takes 1,000 to become infected or ill. Breathing sheds the fewest viral RNA copies and has the lowest velocity particles. And you move up with if you speak, sing, or shout, if you cough, if you flush a toilet, if you sneeze. Sneezing generates 30,000 droplets. They can travel up to 200 miles per hour and can travel up to 26 feet. So that's the size of a 2-car garage or 4 refrigerators stacked on top of one another. So as I said, it's important to have operational data because air quality, depending upon who's in the space and what they're doing and SOPs there, are contributing to that load. In addition to illness and infection, there are a number of very well-respected studies showing the impact of indoor air quality beyond health, specific to cognitive function, learning ability, mental well-being. So it's critical to completely remediate the air serving our buildings, our clinical, and our residential spaces. So as the Congresswoman shared, long before the pandemic, we became extremely fascinated with air quality. And only because we learned over a 20-year period of its significant and negative impact on the level of patient care that we could offer. As a trained reproductive physiologist, I was honored to serve as a clinical provider of human in vitro fertilization. And over a 20-year period, we learned the significance of airborne pathogens on our clinical outcomes. Once we learned this, we tried to purchase a system that would deliver the air we learned was so critical, and there was nothing available. And that is what led to the genesis of the LifeAife system. But because the technology was originally designed to protect the human embryo, the bar was set exceptionally high. So our goal was to completely eliminate airborne viral, bacterial, fungal, and chemical pathogens in space, no matter what activities were ongoing in that space. That's a very tall bar to set. For the biologicals, we chose the anthrax spore as our goal. Fortunately, not because we were concerned with anthrax, but because if you can kill the anthrax spore, you can kill all other viral, bacterial, and fungal pathogens in existence. And that data is actually not ours. It was tested. We shipped that part of the system to the National Homeland Security Research Center, and they tested it for the anthrax killing. We wanted the effectiveness delivered on a single pass. In other words, whatever entered our system did not exit. We insisted on no byproducts, ozone, or intermediate molecules being produced. We wanted it to operate 24/7 during resident, patient, or staff operations. And the last bullet is probably personally the most important to me. It had to be evidence-based. We had to lead with data. So again, if you provide a kill of the anthrax spore, you provide a 9-log. 6 log is sterility. A 9-log kill of all of the other viruses and bacteria with which we are concerned. This also just showing some of the more common airborne viruses, highly infectious. And I listed these because they're smaller in size and often can just penetrate the filter. So if we revisit some of our foundation points, again, of the pathogens that cause illness and infection, 69 to 80% are airborne. Greater than 90% of your infectious surface pathogens originate from the air. And lastly, air quality is extremely dynamic, minute to minute. So when you think about that, would there be an impact on facility-acquired infections or healthcare-acquired infections and resident wellness if airborne vectors of illness were completely remediated? That hypothesis is what led to 2 large independent IRB-approved studies, one with Phoebe Ministries in senior living and the other in healthcare with St. Luke's. One was a 12-month study, the other 15, involving over 8,300 adults. And again, I can't recognize Phoebe enough for their vision towards wellness and excellence in senior care, where we installed the first system in senior living. The system was installed, there were 2 floors that were identical to one another. They were both memory support floors, which I learned from Phoebe are probably the most infectious areas. And so we had LifeAire protected one entire floor, and then there was a control zone protected by HEPA filtration. It was a double-blinded study. Kelly Bach and some of her engineering colleagues were aware of the system, but the residents weren't aware, the clinical staff weren't aware. It was completely double-blinded. And we collected data both environmentally and clinically for 15 months until hitting the proper power. Their system was placed on the rooftop. As Kelly shared earlier, the building was built in 1903, and so there was no space above the ceiling. So we put the same system that we would have put above the ceiling on the roof, as circled in yellow. And it's worked out quite well. Again, our goal was just to completely remove airborne pathogens responsible for illness and infection in a long-term care setting. I mentioned environmental data. We used the most sensitive assays that were available, and these still are the most sensitive assays available, to sample all the most commonly touched clinical and resident surfaces, as well as collecting airborne bacterial and fungal data. We collected 11 surface samples, 7 airborne samples, and 5 chemical pathogen samples in each of 5 areas on each floor. It was an extensive environmental study comparing the controlled HEPA protected to the LifeAire protected floor. Alicia is here with us today. She did comprehensive sampling within the resident rooms, and then these samples were sent off to a third-party industrial hygienist laboratory, one of the most renowned in the world, for analysis. So we tested in the resident rooms, resident restrooms, again, the support bar in the restroom, 2 community areas on each floor, testing there, dining areas, and as you can see, all of the testing was done during live operation. Another dining room area, swabbing the handle in the dining cart, because this is pushed down the hall to those residents who may not be able to join others in the dining room, the nursing station, the hallway corridor. And again, Kelly and Bill, you might appreciate this. Operationally, their PTAC units and their unit ventilators ran per course. Nothing else was changed. Again, our goal was to completely remove the vector of illness, airborne loading. You first start any statistical analysis with looking at the demographics of those in the space. And when comparing the control to the study floor by age, etiology, male, female, race, etc., there are no statistically significant differences. And this is very important so that you know none of these influence the data in a positive or negative fashion. We look at the results, and again, there are hundreds and hundreds of data points to share, but I've narrowed it down to 3 slides. I don't want you to worry. So, when you look at the study floor, before and after installation, we did a lot of before and after testing. We did testing during, obviously. If you look at the number of viable pathogens, so this is the number of living bacteria and fungi in this space before installation of the technology and after in each of the 5 rooms, each of the 5 areas on each floor. So you have resident room annex, resident room wing, before and after, corridor, the community area, and the dining area. And you see statistically significant drops in the, or decreases in the amount of infectious airborne bacteria and fungi in those senior living residential spaces. When you look at the VOCs, now this was important, this was a surprise, because when we presented to the Phoebe IRB committee, medical director shared with us, he admits as many senior residents to the hospital for exacerbation by VOCs, your chemical pathogens, as he did by infections or other illnesses, because they often have compromised respiratory systems, whether it be COPD or reactive airway disease. So remediation of VOCs was very important to them in the senior living setting. So you can see the statistically significant decrease in VOCs before versus after installation in each of the same 5 areas per floor. Relative to the facility-acquired infections, and again, they just shared with the epidemiologists what they were reporting out. If you look at the summary of the data from October 2018 to January of 2020, comparing the control floor protected by HEPA to the study floor, they demonstrate a decrease of 39 percentage points in their infections among their residents. This slide is one of my favorite. I know it looks busy, but they were kind enough to share their microbiological data. So These are the organisms that were cultured from the infected resident on the control floor. These pathogens were demonstrated, were shown by the environmental studies present on the control floor and completely absent on the study floor. So this was a direct relationship between the pathogens that were found on the control floor and the illness or infection that they caused, and being absent on the study floor. So in summary, they had an 89% reduction in infectious airborne pathogens, an 88% reduction in surface pathogens from the environmental analysis that was done, a 90% reduction in VOCs. So you're basically removing 3 common vectors of illness or infection from the residential spaces for those seniors. As far as the secondary outcome variables, they showed a reduction in infections of 39%, improved resident wellness, and honestly a metric that was not part of the IRB study that they brought to our attention was a 47% reduction in staff call-outs. So the residents were staying healthier, the staff on that floor were staying healthier. So they had a 47% reduction, and thus a reduction, again, as we've learned from them, a reduction in clinical care failure when you have to bring in staff who may not be familiar with the residents, and there could be an increase in care failure incidents. Economically, they've shared with us there's a positive impact on the Medicare fee for service, increased quality of care, incentive payments, being named as a preferred provider, receiving 5-star ratings from CMS, and again, the messaging to the staff in their level of protection and increased clinical continuity, the staff who know the residents are there, and reduced clinical care failure. Close to the same time period, we were finishing the study with St. Luke's. A completely different study, but set up in a very similar way, where we had one medical surgical floor protected by the technology, and then compared it to a control med surg floor protected by HEPA protection. Their data involved over close to 8,200 adult patients. We reached that number and hit proper power in 12 months. Their data in a rapid summary showed a reduction of over 99% of infectious airborne pathogens over the control HEPA protected floor, 97% reduced in surface pathogens. So again, the goal of removing 2 common sources or 2 common vectors of illness and infection. They showed a reduction in their healthcare acquired infections and readmission rates, but their reduced length of stay was statistically significant. So their reduced length of stay was approximately 39%. When I shared this data with the CFO of the network, I said, I understand what these numbers mean clinically. What do they mean to you? And he said, well, first of all, improved patient care. Second of all, more heads and beds. So he said, you're starting my billing cycle over faster because I have a 39% reduction in length of stay. That's a huge economic driver for the hospital. In fact, they saved $173,000 per patient bed in a 12-month period, which was significant. And he said, just improved capacity of my existing real estate. So in conclusion, we've learned over decades that airborne and surface pathogens constitute a significant source of illness and infection. So by dramatically reducing these 3 common vectors of illness and infection during live and a fully operational clinical setting, the residents and patients on the protected floors demonstrated statistically significant decreases in illness, infection, readmission rates, and length of stay. And then the staff call-out rates were dramatically reduced on the protected floors, supporting the hypothesis that environmental factors impact resident and patient wellness. So our genesis selfishly began with human in vitro fertilization, desperately trying to protect living human embryo for 6 days outside the body. But we're now honored to be applying that technology, again, because the bar was set so high for the human embryo, applying that technology to those in acute care setting, in healthcare, and now those in senior living, both the staff, their families, and the residents. We're honored our installed base of clinical providers have really become lifelong academic and clinical partners, continuing to learn more about the mechanisms of transmission of airborne viruses, bacteria, and fungi. So we continue to publish and present together, and really just learning how to push the technology and continue to improve all towards patient care and resident wellness. So I thank you.
Can I just ask a question? Kate, do you foresee the day when this will become standard of care from a legal point of view for a long-term care facility to have this kind of, I mean, I know there's a big capital expense involved and that kind of thing, but it would seem, and this isn't the kind of thing the average patient or patient's family would know to ask about, but given the numbers that you just showed us in terms of, reducing infection and that kind of thing, it would seem that eventually that's where it's going to be headed.
And I think there's just been such increased awareness of airborne transmission just with the pandemic as well. And just with, the results and the data with our study with Phoebe, I think it would just be a dramatic improvement, for the resident wellness and their well-being.
I'm not going to be able to stay if you know
I
that,
know.
because I have another, worst part of this job is being overbooked all the time. And I didn't introduce Selena Winchester from my office, but Selena's going to stay. But thank you.
Thank
This
you
was really
very much.
helpful,
Thank
and
you
I
for
hope
being
you
here.
all get a lot out
And
of
for all that you're doing.
the round table and anything that we can do, and I know that we are working with you already,
Yes.
because I'd really like to see this be something that takes off. And so we know that you've installed in the airport. Now, what other kind, outside of the healthcare world, where else are?
Well, we're very healthcare centric. I
Right.
mean, including senior living, obviously. But I have to say, I was very impressed with our airport. They could have just checked the box for air filtration, but they specifically said to us they wanted a proven system in healthcare that was tested during live operation. I remain impressed by that.
Yeah.
That was their mission. So, and we're honored to be protecting Ben Franklin.
That's great. This is only the
excited.
beginning, right?
Thank you
Thank
so
you.
much.
Thank you, Dave.
Thank you. Okay, so at this time, we're going to move into the open roundtable discussion. We're very fortunate to have Erica Kimmerling from the Office of Science and Technology Policy joining us virtually, who's going to make a few comments, and then again, we'll have some comments from Michelle from Phoebe, again from Bill with Country Meadows. Obviously, Selena is sitting in now on behalf of the Congresswoman, and we'll be taking notes and taking messages back to her. And then it's just an open discussion. We want to hear more of kind of like what we did earlier, very good sharing of information, but also there may be questions, there may be different needs that we want to talk about. And we're fortunate also to have Austin here from Leading HPA, who will be able to speak a little to some of the funding that is available out there and some of the new things that have been released. So with that, Erica, if I could turn it over to you.
Good morning. Can everyone hear me?
Yes.
Yes, we can.
Fantastic. Just wanted to make sure. So I wanted to thank our host for the invitation, Congresswoman Wild, who I know just left, but her work on this critical issue, and to everyone who's already shared their stories. My name is Erica Kimmerling. I am the Senior Policy Advisor for Public Engagement and Science at the White House Office of Science and Technology Policy, or I'll refer to it as OSTP. I'm actually a scientist by training, so I'll admit following all that data from the previous presentation kind of feels like a tall task. The data does really tell a compelling story of the importance of clean indoor air. Despite being a tough act to follow, I do want to provide some insights into how our office and the administration has approached the topic of clean indoor air. So the mission of the White House Office of Science and Technology Policy is to maximize the benefits of science and technology to advance health, prosperity, security, environmental quality, and justice for all Americans. So we are committed to advancing both equity in science and technology and science and technology for equity. So kind of along these lines, earlier this year, we at OSTP recognized that there was more we could be doing to elevate the science behind clean indoor air as both a means of pandemic mitigation and improving overall health and well-being. So a lot of this work is actually focused on creating that increased awareness that we were just talking about among the general population. So when we talk about improving indoor air quality in a non-medical setting, so kind of knowing that the medical setting is the gold standard for clean indoor air, better air quality can be achieved by doing things as simple as moving activities, well, opening a window, adding a HEPA filter does work to provide some increased filtration improvement, changing your HVAC settings to run continuously, adding high-grade filters like MERV 13 filters. These are steps that all are all additive to improving indoor air quality. And indoor air is what we call a passive measure that provides a layer of protection that doesn't require individual action, improves the health and safety for all. And we believe the science behind clean indoor air is actually quite empowering for people. So one of the things that we like to cite is that by doing something like improving the air changes per hour, so the amount of fresh air that is brought into a room per hour up to 5. So 5 air changes per hour reduces transmission risk of COVID-19 by 50% or more. And improving indoor air also has benefits, as you've already heard, beyond COVID. It reduced the risk of getting the flu, the common cold, other diseases spread by air. Again, that slide did a great job talking about the extent of diseases that are airborne. And it protects from outdoor pollutants and leads to better overall health outcomes. Interestingly enough, one of the things from the data that we just heard was how it reduced staff, the amount of time staff called out. And we actually have cited data from other studies that show that just a twofold improvement in ventilation can reduce sick leave by 35%, and this was done pre-COVID. And if you actually calculate that out, even though these improvements can be costly, the savings can be up to $500 per employee per year. So when you talk about nationally, you're talking billions of dollars of savings. The other thing I want to add in is that we know that things like allergies and asthma, which impact more than 65 million Americans, and other conditions, are made worse by poor indoor air quality. So this is an issue that, to be honest, before COVID was of significant importance to the health and well-being of millions of people, and it was underappreciated and received less attention than it deserved for how much it can have an impact on how people feel. So what has the administration been doing about it? Over the past few months, we have been working with the COVID response team to increase the White House's messaging and activity on this issue. The EPA issued the Clean Air in Buildings Challenge, which was a call to action and a practical guide for building owners and operators, as well as business owners, to homeowners to improve their indoor air quality. We've had increased public messaging through widely attended sessions on the science behind clean indoor air and why people should care. It's also included working with our federal partners to incorporate guidance into how funding from things like the state and local fiscal recovery funds, which is about $350 billion from the American Rescue Plan, could be used for things like indoor air quality improvements. So really, clean indoor air is just a great opportunity to show that the government can do things to improve people's lives. And at OSTP, we're also doing some things that are more on the technical, wonky side, like managing and reducing disease transmission in the built environment working group, with the goal of spurring innovation, communications, and implementation of built environment technologies, like the technologies you heard about today, to reduce transmission of COVID-19 and future threats. So just to kind of wrap up, while a lot of our policy actions have been under what we'll call the pandemic prevention umbrella, our work on clean indoor air really does bring together experts from our health and life sciences team, our climate and environment team, national security, because we know this is much bigger than COVID. And as the head of OSTP, Dr. Nelson has said, for decades, Americans have demanded that clean water flow from our taps and pollution limits be placed on our smokestacks and tailpipes. It's time for healthy and clean indoor air to become an expectation for us all. Clean and healthy indoor air is a fundamental commitment we must make to our children, to workers, and to those who are medically vulnerable, and to every person in this country. So I'm very excited to be with all of you today and answer any questions that you may have.
Excellent, thank you. Michelle, do you have anything you'd like to kick off with?
None at this time. I'm interested to hear what somebody has to say.
And Bill, any additional comments or questions?
No, I guess I could talk a little bit about the, prioritizing senior long-term care. Where do we go with that? I'm happy to say that the recent budget 22-23 year that was, we did recognize the importance of supporting long-term care and the most vulnerable population that we have in the state. Medicaid reimbursements within that plan is going to increase by approximately $35 per resident per day, which is going to be huge in trying to support raising wages for the workers who are supporting those residents, benefits, and also recruitment. We're faced with staffing challenges all over, from getting high school students to be dining aides to nurses, and that initiative is certainly going to help, along with the American Rescue Plan funds to be utilized with personal care, assisted living, and our nursing facilities. So I think that's great. It's finally got some attention. I personally don't think it should have taken a pandemic to do so. It's been a struggle trying to get any increase on that, and I don't think, I think anytime we're talking about funding and supporting our seniors, it needs to be prioritized within the state. So I'm happy that that has been seen and it's going to be recognized, but it can't be forgotten after we get back to normal at this time. And, I'd like to see more towards education for CNAs. LPN is also a need, and I know some of the schools are struggling to get nurses at this time. So burnout is real, and I get it through COVID, but we know healthcare is always going to be a needed industry, and I think we need to be able to send that message and show the importance of caring for others, and it's a career of passion, and we're going to find people to participate in it.
Awesome, thank you. And Austin, if you're ready now. I know,
Sure, yeah, no,
because
Bill did a great job kind of breaking it down, and I have some notes just to give the actual facts and figures of it. So my name is Austin Cawley. I'm the legislative director at LifeAife PA. I'm a part of the government affairs team of the association. So since the spring, we've been advocating for a $294 million budget increase to Medicaid rates in the state. And that's actually in conjunction, that's the state match. There's also a federal match that would be on top of that, so it's about a 50-50 piece. So all in total, it was a 17.5% rate increase, more than $600 million in recurring investment in the long-term care starting in January of 2023. There was also $250 million of the ARPA, or American Rescue Plan dollars, $131 million, which was allocated to nursing facilities, and that would be based on MA days. And we're still working with the department on kind of the mechanisms of how that gets all distributed. 26 million was allocated to assisted living residents and personal care homes, 60 million for home health care providers, and then I believe I also missed, there's also a 3% Medicaid rate increase for life program providers. Let's see what else. We have $7 million for adult day programs, 4.3 million for eligible Medicaid ventilator and tracheotomy qualified nursing facilities. And I believe I also Yeah, so that 3% to life providers was 5.4 million. So in total, like I said, it definitely was a much needed investment in long-term care. It's been a long time coming. You mentioned, I think I started with UNH about a little under a year ago. I was told it was about 10 years since the last rate increase. So much needed. Certainly as the years go on, costs are going up. You certainly all know that. So it, more than ever, Bill's absolutely right. It's a good first step, but we're hoping to continue to advocate. And I think, as we go forward and as we look at, what can be done legislatively and what can be done from a state perspective, things like this, improvements, right? Recognizing that these types of improvements like LifeAire or any improvements to facilities still contributes to the residents' quality of life, and investments in that also relieve a burden on long-term care programs. So certainly something, I think we as Leading Age are looking at going forward of how do we get investment into systems like this, or just generally how do we improve building and physical plan structures as well to help impact residents.
And one thing just to make clear, the Congresswoman, of course, shared her ideas of what she's doing, what she's working on, and Superintendent stayed, graciously to take notes and take those messages back to the Congresswoman. We will be following up with the Congresswoman, her office, the OSTP, and providing follow-up to this, just so everybody's clear. And this is also being recorded, so everybody will have the opportunity to look back at it and pull information out. With that said, I'd like to open it up to comments, questions, challenges, anything you want to share that, again, that Erica, should hear at the Office of Science and Technology Policy, that's something we can take back to the Congresswoman. Any of those, really open forum discussion. Yes.
So I think, well, two things, I think Kelly has a few things to say, but also CPACE. You may want to share that with them.
Yes, so during the budget process, there's also a Senate bill that was passed by both chambers and signed by Governor Wolf. The act number is escaping me. But what it did, so the Commercial Property Assessed Clean Energy Program, or CPACE, which is a statewide program, but then also each local economic development group needs to approve it, or the county needs to approve it through a local ordinance in order to utilize the funds. What the bill did was expand the program. So currently it covered agricultural, industrial, I think other commercial properties, but it expanded it to now commercial multifamily properties, which for long-term care really means independent living, assisted living, things like that. So we were very supportive of the bill. We pushed it to the end. We were happy to see it passed. In one study, and it was actually brought to my attention by a member in Lancaster County, and they estimated, I guess through their own reporting, a $300 million projects. The funding is actually privately, it's still all private funds, there's actually no government funds into it. What it is it's an assessment on your property tax bill at the end of each year. It allows for low interest financing. That's the means of which it is done. Again, not a finance expert, but that's the general explanation was to me. And go ahead.
I'll throw in a couple extra points, because the CPACE funding is something that is very significant in that, one of the challenges for everybody is capital budgets, CapEx money. And that's one of the benefits of CPACE funding is this is not a CapEx hit for a facility. So the way that the program works is, as Austin said, it's privately funded, but it can be completely off the balance sheet. It does not hit your credit rating. It does not hit your ability to borrow additional funds, and it doesn't touch any of the capital monies you have. One of the key components, again, it is property assessed clean energy. So one of the critical components is that it does have to encompass projects that are actually making an energy saving, making an impact. So for example, solar panels are always a no-brainer because they absolutely are cost positive. LED lighting, there's a number of different things that qualify. LifeAire does fit into it on a couple of different levels, both in energy saving but also on the medical side. But the real key component is this is not something where a sales rep can come out and say, buy my thing and I promise it's going to pay for itself. Just trust me. This is something that you don't decide if it's going to qualify and save enough energy. The companies don't decide. There is a third-party engineer that has to come out and assess any projects you do and certify that over the course of the term of the funding, you will pay for it in energy savings. And so it is cash flow positive from day one. So you're not taking CapEx money out, but you're also not truly spending money along the way because your energy savings have to outweigh the cost of whatever project. Again, whether it be solar panels, LED lighting, etc. And so that's something that, if anybody has additional questions or interest, I'm happy to talk about that later, but it is a really significant opportunity. And, to Austin's credit and everybody, Pennsylvania is really ahead of just about every state in the country with CPACE funding and how readily available it is. So we're in a great spot.
This is a very new program. It's
Yes.
approved in, is it 36 states?
38.
38 states? But it's very new. In addition to the funding that you graciously shared, so I wanted to mention
Absolutely, yes, absolutely.
another totally different source,
Yeah.
all towards helping our senior providers.
Absolutely, I think when it comes down to it, it's a great system, but again, it's how to make it work
That's right.
practically, how do you pay for it? Yeah, that's great. Really great mechanism.
Kelly, I didn't want to exclude you.
Yeah, it wasn't, I just wanted to, you had all your clinical documentation up on the screen from LifeAire. But from an operational perspective, like I'm an operator, right? So, the LifeAire team, amazing group of people, but the one thing that I wanted to note, and nothing dramatic, but just to know that the Bridgeways unit, which is a unit that had the LifeAire unit, did get COVID, but it got it 6 months after everyone else. And it was brought in by us, because they live there, right? So it's brought in by us. So it held it at bay for a while, but they are a great group of people, and the LifeAire system was probably one, like I'm a 32-year veteran of my field, and it was ranks in the top 5 things I've done in my career to make senior living a better place.
I have a question for Erica. On the way out, the Congresswoman was asking Katie about does she believe that this will ever become standard of care, and I'm just curious about where you see regulations or changes or what we might see coming as far as indoor air quality in an arena like long-term care.
Yeah, thank you for that question. And I think, there's a bit of a chicken and egg thing that has to happen in terms of there has to be momentum and demand for these increased standards in order for them to actually get implemented. And the interesting thing that we've found out in doing this work is that, the government the federal government doesn't set building standards, especially healthcare settings are a little bit different, but for general building standards, professional societies such as ASHRAE pull together the best experts in the space, do a consensus process, and then state and local governments usually set the standards within their areas. So I think as we start to recognize and have this conversation more and more, I am hoping we can catalyze that kind of action, and the drive for more standards. But, you know, we do have this opportunity now, so we're kind of using the soft power and doing things like encouraging people to take the challenge or pledge to a clean air buildings challenge to get there, because standards will be a little bit longer of a process, and, you know, the professional societies have not started to put those in place. For general buildings, I do not know for, you know, where senior centers fall under the spectrum of healthcare facilities, and who their governing board is, so I can't speak to that specifically.
Okay, thank you. I said another question. Oh,
I have a question. So as we talk about this, we're talking about a piece of equipment that is a substantial expense in a long-term care environment. So I believe that in order to expedite that to somewhere else, we would have to have government support, some sort of funding from the government. So I think that that's a place that we need to start to think. We can't say, you can't mandate that a long-term care facility improve their air and not give them support to do such. Not really a question, it's more of a statement. I guess it's more of a statement, sorry.
To add to that, so currently the nursing facility regulations are actually, final form should be released relatively soon, I believe in October. We're expecting that. Now there's multiple pieces to this package. Again, legislative, this is regulatory, but a little bit out of our realm here, but with any type of regulation, if we're to be implemented, the regulation body does have to create a financial assessment and impact what that regulation would be. So,
Going through it right now.
Yeah,
Well aware.
that would be, but yes, that's, so yeah, I think no matter what, if this were to become regulation, there would have to be some sort of recognition that there is a financial impact.
And with the new funding that the government passed, is that Medicaid only? Is that Medicare as well? How is that?
So it's just Medicaid.
Okay.
Dave, if I may,
Yes, please.
the state is also sitting on a large chunk of money that came down from the federal government that has not been yet allocated, and that has, the legislators have not decided on how that money is going to be used. So to Kelly's point, and I think you had exchanged emails on this, some of the funding that has come down and went down to our small businesses or to our counties, they didn't even know how to use, and some grabbed out that money immediately. So a lot of counties are sitting on funds that they receive from the government, from the state. And there is a lot more out there in the bucket that we're hoping, you know, for example, you know, when I go back to say, this, you know, this is still needed. I'm advocating for LifeAire and getting people a little bit more help. But there is money out there again. And so it's not a lost cause to say we can't help facilitate providing something like a tax credit program or something like that to get these businesses to start putting in these air filtration systems. So there is hope out there. There is, it's just how do we get it in front of our elected officials to push this as a priority. You know, it is a priority. So how do we get that word out there? That's been a challenge. That's why this type of a forum is very important, so that more people tell their stories so that information gets out there. Because those legislators are not going to allocate that funding to do something like this unless somebody's knocking on the door talking. I'm just talking straight, shooting right from the hip. But there is money out there still. And I have to say, when you were talking about the feedback and the reporting, one of the things that happened at DCEDs when the governor shut everything down, we got like an knowledge notice, and many people in our department became healthcare representatives and talking to the health. So I never wore a hat like that before. But one of the things that I learned right from the get-go is that we had a lot of small businesses that were able to change gears, you to create manufacture hand sanitizer or masks and things like that. And we gave feedback immediately saying, okay, now we've got to come back and help these small businesses that are doing things that we need done here in the state. But the reporting system, we were getting hit. Everybody was calling how cumbersome it was for the reporting system. And as DCD, I was in the health department, but we were able to report back that they can't do this. This is too much for them, and we were able to help streamline it. So the state wasn't prepared for COVID. I mean, we didn't even have the staff capability of handling everything that came our way all at once, from businesses to closing to supply chain, and all the cases that happened. And I just know now, going back, even as we're still trying to evaluate how we handle things, and obviously not everything was handled well, there is room to improve how we did reporting, how we communicated. And again, I agree, on every Friday, it was. Oh, now we're going to do this. And we were changing. I could talk to a small business company one day, and the next day I had to call them back and be like, we just switched that, I'm really sorry. And again, we were flying blind for a lot because we were waiting on the federal government to tell us what to do and give us our guidelines, and then we were constantly changing here at the state. So again, there is, some of the counties are sitting on money that they were just given, and some have used it all up already, or used it to projects. But our state legislators are sitting on a good chunk of money right now that could be advocated for things like this.
And Fania, is that money sitting at the state level, at the county level? Where?
It's federal money that was given to the state.
Okay, so
we are at liberty to decide how we're going to use it.
Okay.
And that, most of those funds will go away on the forward, correct?
Right.
Yeah. So there is also a time limit on when you have it. So.
And whether for you or for you to take that to the Congresswoman, the big ask or question then, and we've talked about this, is how do we help people access, how do we help people get to that money? If the money's there, it's going to go away if it's not used. So what can we do to help them get to those funds? That's an important piece of the puzzle.
I would say, as far as the county level, you need to advocate to your county commissioners or county executives, let them know what you need. When that money came to them, everybody was like knocking on the door, we want funds. You should also be going to your state reps and your state senators, because they're the ones that have to advocate for that money that's still sitting there. And you need to talk to them about, hey, we need this. And you shouldn't be shy about it at all. That money's there for a reason. And, I could go back and say, I've helped some of the counties, apply for the money and just help them figure out their projects. But a lot of them were not ready for this influx of money and didn't know, the language is so broad. So we had to look at it and say, okay, well, this kind of fits. How can we make this fit? And when I was talking to Dave, I'm like, you know what? We probably could make getting this air filtration system into senior homes fit the money that the counties got. But the counties didn't know that. And there's not enough, communication or training. A lot of the people that are applying for these loans and the funds, and they don't know how to do it themselves. So again, this is a huge learning curve, I think, on every level in the state and in the federal government. And there was a lot for us to learn looking back now. But again, you have to make your case. I Kate about the airport. I'm like, we got to get you back in there and get the governor there, because if he sees the system working at the airport, then that's how it works. It's kind of like, it's a domino effect. And I'll back channel and go to try to do that, but you have to get in front of it. Again, I think your first calls have to be go to your state reps or state senators and say, hey, I heard there's a chunk of money out there. You can tell them
Now, I was recently at a leading age meeting, and there was some discussion. Somebody stood up and said that they had received FEMA money, and it allowed them to do improvements. Do you know, or is that something you can look into? Is there FEMA money still available? As it was the pandemic was was considered a disaster, of course. And I know a lot of the money went towards PPE and things like that, but apparently there was money available for structural improvements or things like, you know, what LifeAire would do to increase air quality.
Selena might be able to help with FEMA, but, you know, for Pennsylvania, we did have money. I don't think that is something that we could look at anymore. I'll go back and ask,
Okay.
I'll follow up. I don't really know if we used it all, but I know that we were all operating from one headquarters in FEMA.
Okay.
And so that money was used even for that, and trying to bring other people in to help us here in the state, because we did have to bring people in to help, and couldn't keep up with it. But I'll definitely go back and try to find an answer for you.
Excellent. And there is an online question about is LifeAire, can LifeAire assist with guiding a client on funding opportunities, or do they have to do it on their own? You know, kind of as you hear in this discussion, we've been talking about this topic for a while, and we are working very diligently to try to help that process and find the right path to help people get to the funding. And we're working with numerous different professionals, whether it be people who are used to writing grants, attorneys, et cetera, to help us figure this out. We're not experts, we're not funding experts and can't get it for you, but we certainly are working very hard, and the Congresswoman has been very helpful in understanding that is probably the biggest challenge of the funding is how do we go about getting it. And so yes, we are assisting in every way we can as somebody goes forward, and can certainly help with the CPACE process as well.
Dave, I just had a question for Erica Kimberly. Is she still on? Erica, are you still there?
I am still here.
Yeah, as a scientist with the White House, I'm just curious, are you familiar with any other studies in the literature that looked at outcomes mitigating air, that was a double-blind randomized control study that was as rigorously done as this in a hospital setting and or a senior living setting and published in peer-reviewed journals? Are you familiar with any other publication like this showing improved outcomes?
So, I am not familiar of any other peer-reviewed publications in this setting that have shown improved outcomes. There's other studies that have shown improved outcomes in schools. Particularly, there's several studies in schools, and there's a lot of studies that do simulated aerosol transmission and reduction of particles. But in terms of like clinical outcomes within this setting, I am not aware. And in full disclosure, even though I am a biomedical engineer by training, I actually do work across all of the teams at OSTP. So I can actually check with some of our other technical staff who are a little bit deeper into the literature to see if they know those studies. But the studies I'm aware of are mostly in different settings and not this rigorous. And in terms of, I don't think I've ever seen it controlled within the same building in the same way. It does seem to be a unique study.
Thank you. Okay, at this point, any of the panelists, anybody here, any final comments, any final questions that you would like to add? I will just throw in, this whole roundtable really was the brainchild of the Congresswoman. I was fortunate enough to be sitting actually with Austin in her office back in March, and we were talking about this exact topic that we've shared a lot about today, that the nursing homes, senior centers, anybody caring for seniors really unfortunately did not get shed in a very good light. I'm being polite about the way I say that, through the pandemic. And all of you and all of the senior care workers across the country, as we've heard, worked tirelessly, did things, a lot of times without guidance or every Friday changing guidance, and really put in exhaustive efforts to try to protect our most vulnerable citizens And unfortunately, that wasn't shown and it wasn't portrayed in the media in the best light. So Congresswoman listened to us, knew that this was the case, and it was her suggestion that we should have something like this and have a roundtable to really show the other side. So it's a shame she's not here, but wanted to thank her for really having the idea to bring this together. And Katie, I'll turn it back to you for any closing comments.
No, well, I mean, I agree with you. I mean, like you said, the genesis of this idea with the Congresswoman and her staff. And just, thank you to each of you for all that you've done in taking care of, our most treasured residents during this pandemic and going forward. And, we've all learned so much. I think we continue to learn from one another in going forward. And I would love to continue the conversation. And as Dave said, we will report back, after all of your suggestions and questions are shared back with the Congresswoman, any feedback from them or help in obtaining the funding or who to reach out to, we'll share that with you very soon so that you can leave and know best how to obtain some of that. But we just wanted to introduce the heroes to those supporting the policies to support the heroes and and taking care of our seniors. And so I thank you for a great discussion. I thank everyone who's joined us virtually. Erica, thank you, and all other attendees, and I welcome everyone to join us for lunch.
Thank you, everybody.
CNDC or the, yeah, well, I'll shoot you an email.